Hello, everyone. My name is Gila Rajayi, and I am the host of the Transforming Chaplaincy Strategic Webinar Series. Today, we're going to be talking about integrating spiritual care at the community wellness level and talking about one clinic's experience, Exalta Health in Grand Rapids, Michigan. We want to again thank ACPE, Transforming Chaplaincy, Templeton Foundation, as they have supported the Transforming Chaplaincy project in the past, and the support and leadership of Dr. George Fitchett. And actually also one of the co-founders of the Transforming Chaplaincy Project itself, Wendy Cadge, who's on the call today. So just a couple announcements as we get started. Just a reminder that we have the networks to develop spiritual care research going on and continuing. You can join them on the Transforming Chaplaincy website. Our sister organization, Chaplaincy Innovation Lab, is doing a town hall webinar on the COVID-19 pandemic and spiritual care within that, and you can sign up on their website for free. We also have the online research literacy courses happening with Transforming Chaplaincy coming up soon in April, and the APC Webinar Journal Club also in April. And many of you already probably are familiar with the Chaplaincy Research Summer Institute, which again is planned to occur this July in Chicago. And last but not least, you have hopefully also heard about our certificate program in spiritual care management and leadership that is done through Rush University. It's a 9-month program. Please get the word out and share with folks about that program, and signing up is happening right now. You can get more information from Andrew Andresco at Rush, and his email's there at the bottom. So through those very quick announcements, just a quick overview of our agenda today. I'll do introduction of our presenters and respondents. We'll have a presentation and then a response from followed by a Q&A. I ask that you use the Q&A box that's within Zoom to type in your questions through the session. We'll be able to respond to them as we go along, and that will, or at the end of this, but we'll be able to see them and collect through the presentation itself. Many of you will ask about recordings and slides. Those will be available after the session on the ACPE website. We just ask that you give us a little bit of time to get a chance to post them. So today I want to first introduce our presenters. And so from Exalta Health, we have the Reverend Kristin Mayer. She's a staff chaplain and a spiritual care coordinator there. She's ordained as a specialized minister and endorsed as a chaplain in the Reformed Church of America. And she's served at Exalta Health since 2017. And with her is Bill Paxton, who has over 40 years of management experience in nonprofit organizations where he's worked primarily in healthcare and behavioral health. Bill obtained an undergrad degree at Calvin College in Michigan and a master's degree at Michigan State University and Aquinas College. And he recently retired as the president of Exalta Health. So we're very glad to have both of you here in your different roles and capacities. Our respondent today is Wendy Cadge, and she is a professor of sociology and women, genders, and sexuality studies at Brandeis University. She is an expert in contemporary American religion, especially religion related to public institutions, religious diversity, and healthcare. She is the author of Paging God, Religion in the Halls of Medicine, was the co-director and founder of the Transforming Chaplaincy Project, and most recently launched the Chaplaincy Innovation Lab. And so with that, I'm going to remind you all the question and answers can be put into the Zoom box, and I will invite Kristin and Bill to take it away.
Thank you, Gila. Put my slides up here. Okay. Good. Yeah, thank you, Gila. We are really grateful to you and all on your team for getting us set up to do this today. I think we're also deeply grateful to the Transforming Chaplaincy group for asking this question, for advocating for a conversation about the role of chaplaincy in community wellness and settings like that. While we have some experience to offer today, we also feel like we have a lot to gain from a growing conversation around this topic. So we're excited for this. I'll give you just a little overview of what we plan to talk about today. We've prepared a webinar that comes directly out of the appeals that you all have been making as Transforming Chaplaincy in recent months for input of people who are working on spiritual care in settings like population health, community wellness, primary care. And that's kind of our story. So, as the title of this webinar indicates, we're going to share from our own experience, kind of providing the on-the-ground perspective of what we've discovered through our own efforts to integrate spiritual care where we are. So we don't intend to offer anything definitive, but we do hope that as we share some of what our process has been like, and the model that has come out of that process, that it will give those of you who are listening or watching kind of an idea of the kinds of questions we've had to ask and think through as we've sought to tailor spiritual care to our kind of unique setting. So we're going to give you a little idea first, just who we are and what we do as an organization. Our context will be helpful for understanding how we've chosen to go about integrating spiritual care. We'll talk a little bit about the distinctive aspects and opportunities that spiritual care in a primary care setting presents. We'll also talk about some of the challenges we've encountered through our process, and specifically challenges that come up as we think about caring for the whole person in a setting where we're working with vulnerable populations. So we'll talk about what we've learned and how it plays out in the model we're using, and then we'll finish off with just what we've seen rise to the surface as the contributions that a chaplain makes in our setting. So with that, I'll hand it over to Bill to fill in the picture for you about our organization.
So Exalta Health is a faith-based nonprofit. It was formed in 1996. We're part of the whole healthcare safety net system. We're not a federally qualified health clinic, FQHC, and we're not what's sometimes called a free clinic, but sometimes it's called a hybrid clinic. And our mission is to reflect the Spirit of Christ by providing compassionate, accessible healthcare. And we do that right now by providing primary medical and dental care to low-income families. So our desire is to be your primary care medical home or your dental home. And how we do that, or what we do is what our population we're serving is, like I said, a low-income population. About 67% are Latino, self-identified that way. Also serve a number of refugees. I think last year, 14 different languages were used to communicate by patients to us in the clinic. Low income means that everyone is well below what might be an affordable, livable wage. Most people, in fact, are below 100% of the federal poverty index. About 75 to 80% of the patients we serve are without insurance, which is interesting because Michigan is a Medicaid expansion state. So you would think that that would capture most folks, and it did impact some of our population. We still have a significant portion of our population that does not have health care insurance. We also see, even though we're primary care, see a number of folks with chronic diseases, including things like diabetes, hypertension, obesity, anxiety, and depression. And how then we want to address that is through a whole care model of caring for the person. So that involves various professionals as part of the care team, as well as screening. So we would like to take this whole perspective of a person in their environment, including their family environment. That means that we understand when a person walks into our clinic, they bring with them their life. They right in the exam room, right in the dental chair is who they are with their environment. And you really can't separate that out and say, well, only bring your medical or dental concerns here. No, we're seeing the person in their life. And so to help address what that means is we have a integrated care team that involves a medical provider, behavioral health, and spiritual care, a chaplain. And we want to address that physical, emotional, and spiritual needs of the person, if you will, body, mind, and spirit, in where they're living in that environment. And we do that in part by doing a number of screenings for people. We screen for anxiety, depression, for the social determinants of health, for domestic violence issues, trauma, and for spiritual care, as far as a quick questionnaire, which we'll get into a little bit more. So again, what we're doing is trying to address that whole person through an interdisciplinary team that works together as a team, and looking at that person and their environment from a number of different aspects. So we're serving low-income people without insurance. Someone's going to ask, how are you funded? How does that work? Well, about 75% of our revenue is through fundraising. We are developing resources from the community through individuals, churches, businesses, different events that we run, and grants and foundations to provide the services that we're doing in the community. Patients also contribute on a sliding fee scale, so they're paying, in most cases, something, maybe a very minimal amount, but something for their care. That sliding fee scales based on their income for the family, as well as the number of people, dependents that income supports. The other way we make the model work is through volunteers. So we have about 250 volunteers annually, ranging all the way from physicians and dentists to nurses, medical assistants, hygienists, dental assistants, to our maintenance and support staff. So we take volunteers in every level, which helps make it more affordable for us to run it. In Grand Rapids, as I said, we're part of this whole continuum of care services, and we do work on a relationship with other healthcare systems in our community. In our community, there's three fairly large healthcare systems. Spectrum Health is a large regional center. Metro Health, University of Michigan. So Metro Health is part of the University of Michigan care delivery system. And that Mercy Health is part of the Trinity Healthcare System, national. So there's three healthcare systems. We kind of view ourselves as Switzerland. We want to remain neutral, but work with all those healthcare systems in providing services. And there's a couple ways we do that. One is we actually ask them for help in what we're doing. So through their donations or support, and it comes in a variety of ways depending on that particular healthcare system. We see ourselves actually as diverting folks away from the emergency room. So there's probably a savings for those healthcare systems. And the other thing that we need to work with the healthcare systems around is actually the provision of our specialty services. So as any primary care might happen, they're kind of a quarterback and they need to make a handoff in many cases to a specialist, and they're often affiliated with a healthcare system. So, but our folks who don't have insurance, who don't have money, we got to help them make connections and try to find ways for our folks to be supported in those specialty referrals. We also need to think about how medications happen for our folks. Medications are probably one of the real challenges for us, but trying to work with how can we access different medications, whether it's through those other healthcare systems or hooking folks up with pharmacies locally. Kristin?
Yeah.
So I think I kind of jumped ahead a little bit, didn't I?
That's all right. We'll fit that in. So I think one of the things that's important to acknowledge when we're talking about spiritual care here at Exalta Health is that we here at Exalta may be approaching that question from a very different starting point than many of you who are listening today. Spiritual care has always been a part of what we do here. It's a deeply held value of the organization. And so there have been people in the role of chaplain at Exalta Health from just about day one. And that's an over 20-year history. So I've never had to advocate for there actually being a chaplain here. It's just assumed. There's never been a question that the chaplain had a significant role here. Having said that, however, while our starting point and our history may be different, we think we share a lot in common with many of you around the question of how to do it well, how to do spiritual care well in our context. And that's what we're going to talk about mostly today. It may be helpful just to provide a quick overview of what the history of spiritual care at the organization has been, kind of as a compare and contrast. So the previous chaplains who held this position were not clinically trained. They were retired pastors. And the assumption was that spiritual care was a ministry of, the way I term it is proclamation and prescription. The chaplains were here to be supportive, to share good news, and particularly good news from our particular faith perspective. There was no documenting of spiritual care encounters. And one of the big things that has changed is spiritual care kind of operated on a convenience model. That is, whoever was waiting for the doctor got a chaplain visit. Chaplains were heavily involved in kind of the hospitality face of the clinic, and their role of passing time with patients was part of that. So with all of that history, you can hear how we've kind of struggled to figure out how to do this differently and do this well. A little bit more context, we are a member of an organization, a national organization of health clinics like ourselves, faith-based organizations, nonprofits, and each of those has their own model of doing spiritual care. Many of those, I believe, are kind of focused on spiritual care as discipleship, more interested in shaping the content of a patient's faith rather than in finding out how a particular patient's faith is functioning in light of their health. So given that history and context, we've been working for the past 3 years to define this differently and find out what it looks like to have spiritual care actually integrated into the care team in primary care. So we'll talk a few minutes here about some of the distinctives and the opportunities that we've seen as we've done this. And one of them is just the idea that we are daily walking with people in adversity. And Bill kind of mentioned this when he talked about how we don't expect our patients to walk in and leave all of who they are and their daily life and struggles outside the door. Bill, did you want to add a little bit more on that point? I think you already.
Yeah, mostly addressed, but just a little bit, I guess. And many of those listening know this as well or better than I, but it's not that healthcare doesn't believe in addressing spiritual care of people, but where we often see it, usually, historically, has been either in the hospital or hospice. And it seems to us, as part of our value-driven, if we're going to address people as they're coming in on a daily basis, on that daily walk, that we need to try to position spiritual care right with primary care. That's where we see people in their daily walk and not just the crises of life that brings someone to a hospital or end of life that brings someone to hospice. But as you walk day by day, your spirituality walks with you. We don't separate that out. So in our healthcare system, that means we got to find a way to do spiritual care in primary care settings.
Yeah. And then the other thing to think about is in a primary care office, we're seeing everything, especially in one that serves a vulnerable population like ours, we're seeing everything from people coming in with ingrown toenails to people who are experiencing end stages of diseases. So it's just a wide variety, a wide range of presenting conditions, and therefore there's a wide range of spiritual care issues that are addressed, spiritual needs. I just thought of, put together a little list of some of the main concerns that people bring with them to the clinic. Grief is a big one. Family issues, marriage concerns, domestic violence, anxiety over children, disconnection and distance in families, discrimination, especially work-related. Many of our patients are bringing that with them. Difficult diagnoses, and with the added burden of limited options for treatment because of their status, their insurance status, life-limiting illnesses, anxiety and depression, and then, of course, financial hardship and housing concerns are all things that I've talked with people regularly about here. Other opportunities that I think spiritual care brings is we have ongoing relationships with patients over years, and also then the opportunity to serve whole families over years. We recently realized for the first time that we have 4 generations of one family who are receiving care here at Exalta Health. So being able to provide spiritual care for all family members. And then last opportunity, and this is a big one, is spiritual care in a primary care setting brings opportunities to celebrate. I think a lot of my chaplain colleagues who work in a hospital setting perhaps don't ever get to hear the rest of the story. And when we do primary care here, we do get to hear that story and see the resilience of our patients in action when they come back. Let's move into talking about some of the challenges that we've encountered. And the first one, biggest one, is communication with both patients and providers about the role of spiritual care. We think this is an anomaly. This is different. What we're doing is different. It's unexpected. It's just plain weird for some patients. So there's a lot of communicating about what spiritual care is for patients. And then,
Kristin, I want to add with that.
Yeah.
It's not just providers of staff. Again, I mentioned we have volunteers. So an interesting twist, volunteers are a real blessing, but they all come with their own, if you will, agenda, their own perspectives about what spiritual care may be. So the challenge of making sure that they're on the same page that we are regarding spiritual care and how it's delivered is a great one when you're dealing with 250 different individuals. Yeah,
thank you, Bill. The pace and timing of a primary care setting presents a challenge. And I have to add here that I've never experienced spiritual care in any other setting. This is what I do and have since I became a chaplain. So maybe some of this is true of other settings as well, but it feels to me like the pace of the patients coming to the clinic, the number of visits here, the time frame in which patients are actually on site, it's limited. It's different from a hospital stay of even an overnight, So finding the window of time for spiritual care. We also have behavioral health, as Bill mentioned. So kind of triaging needs and figuring out how it works for the right person to be with that patient at the right time. And then, in a way, it also, spiritual care here also is a blessing because there is someone who has time enough to sit with patients in their situations. Another thing that brings to mind as I'm speaking is, the kind of the cycle of assessment, plan, intervention that chaplains talk about and use. That cycle gets all thrown out of whack, I think, in a primary care setting. It's either greatly accelerated because I have one visit and don't expect to see this patient again, or it can be disjointed because this patient may be here today and may not be back for 3 months, or who knows. And then last, kind of the lack of research and models, companions on the journey for integrating spiritual care into primary care. That's something that I discovered once I was into it, that there aren't a lot of people who are doing this. So on that note, I will say that some of the best conversation partners for me, and this is conversation partners through Google actually, is just what's going on in Scotland with the Community Chaplaincy Listening Initiative. That has had a big influence on how I shape my understanding of what I'm doing here. So let's move on and talk a little bit about some of the challenges that come specifically with working with a vulnerable population. Bill, do you want to address social determinants, or do you feel like you've done that already?
Just quickly mention it. So I said we screen for those, and there are several things that we actually screen for. So we're asking about people's housing, their employment, their education, their food and food access. And of course, we're dealing with language and cultural issues too. I mean, there's several things you can look at as social determinants of health. But when you're looking at equity of health services and access to those health services, it's just really important to look at those factors.
Yeah, and that comes in, like we've already talked about, as well, the limited options for treatment, for medication, for specialty care. So, for example, a patient with advanced Parkinson's who may have, in a regular healthcare setting, options for treatment. If they're a patient here, they probably don't have those options. So that's a big source of many of the conversations I have. Another challenge here is providing support for staff. We don't have crises all that often at Exalta Health. We don't have codes like in a hospital. I think I can count maybe 2 times in my time here that we've even had to call an ambulance for a patient. But over time, there is a weight that our staff carries with our patients, and that's where the challenge to provide support for staff in that on kind of on a low level rather than a crisis level comes in. Organizational culture and the challenge of influencing the culture has been interesting, kind of building in the cultural humility that our chaplain training speaks of, and especially with volunteers coming in, as Bill already mentioned, advocating for patients. There are things that happen systemically, structurally as part of the organization that need to be challenged. So along with that comes the idea of building respect into our spiritual care protocols, kind of with the compare and contrast I did with the old model of spiritual care here at the organization. Just recognizing the need of our patients to have a say in whether the chaplain even enters into conversation with them. That was an important challenge to overcome and figure out how to do. And then, of course, one of the social determinants of health also, things like transportation. long work hours, limit patients' ability to come for appointments, and that changes the dynamics of how and when spiritual care is provided. One last thing that's not on this slide is behavioral health integration, and our behavioral health specialists here at Exalta Health, they do a lot of the case management type things that perhaps a social worker in a hospital setting would do, but they also do counseling. And so it was a challenge in our setting, having behavioral health so fully integrated to kind of tease apart the roles of the chaplain from the roles of the social workers, and figuring that out. So we'll move now into kind of talking about, given all this context and given the unique opportunities and challenges that we've encountered, what the model that we've chosen looks like. And the questions that we've had to ask and answer in order to get us there. And again, I'll just acknowledge that I don't think we are finished. This is all a work in progress. It has felt somewhat like an exploratory mission, like we're pioneering something, and I gladly acknowledge that we probably have a long way to go here, so that adds to our excitement about having this conversation with a bigger group of people. We're working out more and more what spiritual care is and can be in our setting. One thing that I want to say right from the start as we talk about our model, again, is to indicate the kind of the influence that the Community Chaplaincy Listening Initiative in Scotland has had on the way we've chosen to do things. I'm not sure how familiar those of you who are listening are with that program, but it has, it's kind of woven through what we've decided to do. Based on kind of the idea of an open invitation, and anyone who wants to talk with a chaplain has a chaplain, and the just the important work of listening in this setting. So Bill, you were going to talk about how we kind of started with at the very end.
Yeah, well, I think it's interesting just to note, maybe a side note, that when we started looking at this, was actually we were asking ourselves, what difference do we make in the lives of our patients? And we were looking at outcomes for behavioral health, and we actually got a grant to have a researcher involved, and so we started looking at, well, what are outcomes for spiritual care? And what difference does it make? So a lot of when we talk about our model, evolved out of us asking that question. What difference are we making? What are the outcomes going to look? How can we impact on the lives? And is there a way to measure that?
Yeah, we had it kind of backwards, but that was a good way to get us started thinking about all of the good questions that we needed to ask. I think the first choice we made, and I think this was in order to maintain some continuity with the history and the mission and values of the organization, was to define things broadly. We decided not to limit chaplain contacts to, say, just people who screened positive for spiritual distress. We opted for extending an open invitation to anyone, all patients at all times, to seek spiritual care. So we work with what we consider an invitational model. It provides any patient who desires spiritual care easy access to talking with the chaplain. It lets all patients know from the very start of their experience here at the clinic that we value all parts of who they are, and their spirituality is important to our health conversations if it's important to them. It provides multiple entry points for contact with the chaplain. Anyone can refer for spiritual care. Providers, I don't know if we talked about the fact that we have a dental department. The dental hygienist makes referrals for spiritual care. Patients can self-refer. medical assistants, even our receptionist has referred people for spiritual care informally, kind of ducking her head in the door and letting me know that someone needs to talk. And then I have my own process of reviewing charts and kind of flagging people I've had conversations with in the past, people with high scores on those depression and anxiety screenings that might be looking to talk. One of the most challenging things we had to think through was what do the 3 levels of kind of spiritual assessment look like in our setting? You know, spiritual history, spiritual screening, and then spiritual assessment. We decided to integrate some of the spiritual screening questions into our patient registration forms. So when patients register with us, which is their first step into our process, they are invited to let us know if they have a faith tradition at all, if they have faith community support, how important their spirituality is to them in terms of their health care, and then also if there's any spiritual beliefs they have that might affect how we provide their care. With regard to screening for spiritual distress, that was especially challenging. We had to think that through very carefully in light of the broad range of presenting conditions. You know, as I mentioned, we have people coming in for regular checkups. We have people coming in for chronic disease management. We have people who are in the end stages of, you know, kidney failure, Parkinson's. So how in all of that do you identify the people who would benefit and want to talk with the chaplain? And then add to that the fact that the schedule's packed and the MAs, the medical assistants, you know, they've got to get through a standard rooming intake process as efficiently as possible. So we initially tried asking just a question to kind of screen for spiritual distress or spiritual needs. We found that question didn't communicate well across multiple languages, and it also didn't communicate well in a setting where people weren't accustomed to having this type of care offered to them. We found that question actually raised more question and provided little helpful information. So we really wanted to balance the goals of first respecting the patient's agency and that they get to choose if they speak with the chaplain, but then also letting them know that we value that part of who they are, and not missing anyone who really did want to talk with the chaplain. So we came up with a little intake script that all people who do rooming procedures are trained in. It just says something pretty simple like, you know, we offer spiritual care for our patients. Please let me or your doctor or someone else on staff know if you'd like the chaplain to talk with you today. Then we also followed that up by giving people some ideas of if a patient gives you a blank look after you've said that, or if they have questions, what do you say? Just train them to say, no, the chaplain is a good person to talk to if you'd like to talk. We have posters in all of our patient care rooms, including the dental area that features our behavioral health staff, and then spiritual care, and it kind of repeats the script that we have spiritual care available through a trained healthcare chaplain, and let us know if you'd like to talk. Because of the oddness factor of having chaplaincy and primary care, I do try to meet all new patients. I just do a one-time introduction. So I'm introducing the service and introducing myself. So they just have a basic idea, and I'm able to explain in my own words. We take it seriously that you are more than a body. All parts of who you are as a human being affect your health. That means your spiritual life, your emotional life, your life in community and family. and we're available to offer support in those areas too, if you'd like. Gila, how are we doing on time?
I think you're doing okay. We got a little bit more time,
Okay.
about maybe like 4 or 5 more minutes, 5 minutes.
Good, perfect. Okay, so then the next thing we had to think through after we kind of established this model is how to train staff and volunteers in it, because it is as new and interesting sometimes to the staff and volunteers and providers as it is to patients. So we did training. We did an in-person training, and then we also created a set of videos, just really short, three videos. People can watch them in less than 30 minutes, talk people through the screening process, the kind of the philosophy of why we do what we do and how we do what we do in spiritual care. And then also training providers in identifying signs of spiritual distress, how to initiate a conversation, how to bring a person's spiritual aspect into the healthcare visit, and how to take a spiritual history and identify those signs of spiritual distress. Last thing on that is we just built flexibility into the system. I already said there are multiple entry points for a patient who desires spiritual care. And then as a chaplain, people can make appointments with me. I do follow-up calls, follow-up appointments, walk-ins, phone calls, hospital visits, all of that I'm available to do. So we'll wrap up here and just talk for a minute about what the chaplain contributes here at Exalta Health. As Bill said, that was the first question we wanted to ask. We weren't, that was the first question we asked, and it's taken some time, I think, to begin to see what spiritual care here is doing for our patients and staff. Bill, did you want to add something at this point, or shall I just go through the list quick?
Yeah, I think you're doing great.
Okay. First, obviously, for crisis care for patients who come in crisis, grief issues are big there, domestic violence, those types of situations, or when a patient receives a difficult diagnosis, obviously. The chaplain has a big role in those conversations. Conversations with patients about medication and how that interacts with their spiritual beliefs, and whether taking medication is in line with their faith. Chronic disease support, that's a big one because we have so many patients who are struggling, especially in our context with diabetes. And having those conversations, having the chaplain here to witness even the daily battle. That's the word that our diabetes patients use, the daily battle it is to take care of yourself. That's been a big role I've had. Patient satisfaction. In the end, when we decided to measure outcomes, we opted for two just what's the word I'm looking for? A feedback form where patients can give just their evaluation. Was the spiritual care you received helpful? And what's our other question, Bill? I'm blanking.
Yeah, I'm blanking right now too. I think the idea though is that patients know best what impact this is having.
Yeah. Did you feel cared for and listened to today at the clinic? Staff and volunteer support is a big part of my role. Prophetic challenge to the organization, to the systems we have in place. Lately, that has come up around the question of standards for interpreting in rooms. Just to give you a really quick look, providers doing asides with interpreters in English when the patient doesn't speak English is something that I've particularly addressed to be able to point out how not in line with our desire to respect all our patients. Something as little as that is, it's significant. So I've initiated that conversation. And then the other one is just being here to listen to, and the words I use are to hold the stories of patients. And this comes more, again, out of the Community Chaplaincy Listening Initiative, the idea of listening as a spiritual activity, that storytelling is important for community resilience. And along with that, often I find that one conversation with a patient where they're able to share their story and feel known and heard here is hugely significant for their wholeness and for opening the door for healing for them. So we probably don't have time. We haven't really.
Can I add one more to that?
Yeah, sure, Bill.
Just to end with this then too. So I think that part of being part of the team for Kristin is the gift of hospitality too. We want to be, I guess, cheers where everyone knows your name. So having someone that knows them and their situation, and this is a warm, inviting place to be and a safe place to be, is really an important part of the role that the chaplain plays.
And that's it. That's what we got.
Super. Well, thanks, Kristin and Bill. I think my job here is to respond just for a few minutes, and then we're going to get to your questions. It's really wonderful to hear about the work that you're doing and the way that you've been doing it for quite some time. And I was really happy to hear you talk about the groups in Scotland who are doing the same. So there are two studies that I'm aware of that have looked at sort of the effects of these kinds of primary care-based chaplaincy models. And I think Gila has the articles, or we could share them for people who want to see them after the fact. My sense is that both of them show positive benefits for the patients with whom or who are involved, right? So they set up these community listening services, and chaplains in two different areas in England and Scotland have had the opportunity to spend as much time with chaplains as they want. And the data all shows that that's really positive for the patients, but also may have some secondary effects on staff. So my main question sort of as you continue is how can we, or maybe you've already done this and didn't get there today, but how can we start to think about measuring this so we can try to figure out kind of what benefits visits have? I wondered if you wanted to say a bit more about who you see. It sounds like anyone can see you, but I would be curious as other places might think about trying this, if there's more to say beyond what you've said about selection. So I guess my questions, and then I want to just stop, is can you or have you tried already to gather some data so we could try to look at effectiveness on patients and families? It sounds like you're using different measures to select patients, but if there's more to say about that, I'd be curious. And then I wonder if you have any sense, anecdotally or otherwise, about the effects that this kind of work might have on staff, and if you wanted to say something about that.
Bill, I see you writing. Do you have some thoughts you want to share?
So just on the gathering data, we have data for our medical patients in particular, and actually for dental patients in a little different ways about the impact of services on them. But we also are looking at some of those biometrics. And what's difficult about that is because we got an interdisciplinary team, we're not isolating, well, if you had this without the chaplain, what it would look like. But we can, so I think that's kind of the challenge when you look at actual biometrics with it is, well, who's having that impact? And we think the team is having the impact, coming at it from all different angles. Impact on staff, maybe a little bit. We've got kind of a sister clinic here in Grand Rapids that we work a lot with. In fact, we share some staff with. Our medical director is shared and our social work staff are shared. They do not have a chaplain. And I would say that the staff's report is that there is clearly a different culture, which may be true with or without the chaplain there. But I think the words, when we were looking at some cultural differences between the two that I think are impacted by chaplaincy, are really have to do with being cared about, listened to, empowered, a part of even decision making. And I think the way Kristin operates as a chaplain in that ministry of presence and listening is true for what her work with staff, and I think that makes a difference for the corporate culture on staff.
Thanks, Bill. And then your other question, Wendy, was focusing more on identifying which patients. Yeah, and I guess I would say that feels to me a little unfocused here at Exalta Health, because we kind of do have this hybrid model where we are inviting anyone to talk with the chaplain, but then also doing some screening. Like I said, I review all charts every day at the beginning of the day and just identify patients that I've talked to before, patients who have had high screening scores in anxiety and depression. So those are the big ways that I guess if you want to talk about, we funnel patients to conversations with the chaplain. And then I'd say that especially our patients who are struggling with grief, those are definitely the ones who always talk with the chaplain if they choose. And the staff is pretty good at the dental staff. 2 weeks ago, we had the dental staff come to find me because they found out about a very recent tragic death in a family that are all our patients. So
I'm asking these questions because from a research perspective, you would want to be able to compare the people that you do and do not meet with, right? To see about effectiveness and to think about what your process is to bring people in. This may or may not be a study that you want to do, but I think as we've talked with other primary care clinics, some of whom are really eager to try this, they're looking for the evidence to justify the budget lines. So, I'm just going to talk about the data, but if there's any way to, get some data, I think it would help. Gila, can I turn it back to you to take some Q&A from the audience?
Perfect timing. Yeah. So first question we've got right now is, Kristin, I'm curious to hear what the spiritual distress question that you tried asking patients that wasn't well understood and didn't end up being helpful. Sometimes we can learn a lot from what doesn't work.
Yeah. And this one really didn't work. Let me see if I can pull it up. I think it was just a pretty open-ended, do you have any spiritual concerns today? So we left it open-ended. Again, that's kind of been the model that we've operated with, open-ended, left it like that, but quickly found out that that didn't translate well.
Yeah, and literally, we're talking about translating. We got, I think it's 71% of our patients have a primary language other than English. So it sounded like, that's a question you can answer in English. We know what that means, but none of the other languages did.
Which is definitely problematic for sure.
Yeah.
Yeah. Another individual, hi, this is Xavier from Washington, D.C. Bill, are you guys following a more allopathic model or is this more integrative? And I know you've kind of talked about this, but just getting more specific.
Yeah, it's an integrated model, both for behavioral health and spiritual care. So we work as a team. Everyone has access to the same electronic health record. You're teaming on patients together. You consult with each other and work together in that way.
Brilliant. Does anyone else have any other questions? I'm looking in the Q&A box currently.
I just want to add one piece when you talked about integrated model. We mentioned that before, but it really is on the challenge too, that sometimes the way social work, behavioral health approaches issues and chaplaincy can have a real overlap. So I don't want to underestimate the work that we had to do to say, so who do we make a referral to? Social worker or the chaplain? And what does that mean? And we ended up saying, there's no wrong door here. So who's the patient comfortable with? Was one of the criteria that happened then. But it just really has to do with when you're, really the integration is what raises the question for me, but you have overlapping spheres of influence, if you will, and of expertise. They're not square boxes that are neatly pushed off into one role or another role, but you really have those overlapping spheres of influence. You got to really respect each other and work together with each other. And we're really fortunate, thanks to Kristin's and behavioral health staff's leadership and personalities, they work really well together.
Mm-hmm. Another question coming through says, as a community center, are you finding patients seeking to connect to a faith community or struggling with their faith communities?
Both. So yeah, there are not, I guess it wouldn't be often, but I do direct, offer input and provide referring patients to faith communities here in town. And then, yes, sometimes we do, one of the conversations that we have is when there are issues with the faith community. So both answer to that.
I think the other piece of that too, I guess we didn't deal with it directly, but we have a number of folks who do not have legal documentation to be able to get insurance, for example, or actually to be in this country, or are afraid of that. Maybe they could qualify, but they have a very close relative, someone living with them, parent, etc., whose legal status is such that they are concerned in today's environment. And I'm bringing it up because you need to have trust in institutions, and that's really difficult right now for a lot of the people we deal with to have. So we really work at being a trusted place and a comfortable place. And so someone may not trust another institution, but we may be the place that they're trusting.
Yeah, that's fair, especially right now. One of the comments is, Bill, is clearly you all have done a really good job fundraising. Do you think there are any donor funders out there that want to help with some research about who is seeing the chaplain and what impact that's having, and transforming chaplaincy? A la George Pachet, whose question this is, would be happy to be a part of that team.
Yeah, great. I think there may be. We got a gift from a private family foundation here in Grand Rapids that when we originally looked at this question, and I think there's possibilities that they may want to do a follow-up thing. They certainly have the means to do something and they have the interest, so that's a possibility.
All right. We probably have time for one last question. We're coming up on the end of actually we're about at the end. So I just want to say thank you to all of you today for being here and with us. We had more questions. I apologize that we aren't able to get to all of them. But thank you for your presentation, Kristin and Bill. That was fantastic. And Wendy for your questions and response. As always, we have our slides will be posted. The recording will also be posted on the ACPE website. And we just invite you to pay attention. We'll be announcing our next webinar, strategic webinar, coming up soon. So look for that in the Transforming Chaplaincy newsletter. And until then, thank you everyone for being with us today. And we look forward to the next session with you.
Thank you.